Hey everybody, this is Eric back with you. We're going to start a multi-level ventilator management series. We're going to take it all the way from the very basics all the way to advanced concepts, really focused educational content. Come join us today. We're going to look at specifically tidal volume and rate, all the stuff that encompasses that, new studies, new theories, new thought processes, and how we can start applying those things to our patients. So come join me inside and we'll see you in a few minutes. Hey everybody, this is Eric back with you. Today we're going to jump into a video series on ventilator management. I know we're going through right now a video series on advanced hemodynamics, but I think it's important that we maybe cover two different topics, so I'll be posting a few videos a week on these two topics. The ventilator management topic is something that is extremely broad. It's something that we can apply completely different when you look at transport medicine, when you look at the HIMSS industry and pre-hospital critical care. So I'm going to kind of go through my thoughts based on my education on it, my experience on it, and we'll go through a multiple layered video series on transport ventilation. Today we're going to just jump into aspects of tidal volume, how we actually take in a breath, and respiratory rate. And that's going to move us into other topics related to this, and we'll kind of move all the way down until at the very end we're looking at case studies. We're applying the different approaches, the different strategies, and hopefully you'll enjoy this video series. So let's jump in. The mechanics of breathing, if you think about how we take a breath and you apply that to how we deliver a breath with a ventilator, it's completely different. We have actually a negative pressure in our chest. And as we actually try to take a breath, or we take a breath, our chest wall expands, our diaphragm flattens out, and just that process alone brings air into our chest cavity. So we actually have a pressure gradient change. We go from a low pressure to a high pressure. When we actually exhale, the exhalation process, the CO2 process where we're getting rid of that CO2, that's a convective process. That process is something that takes a little bit more effort. We don't really notice that in normal homeostasis, but when you start dealing with your patients as far as placing them on the ventilator, applying the different disease processes, especially obstructive lung patients, that can be a big deal, dealing with that CO2 regulation and getting the air back out. As you can see with this illustration, when we actually expel that air back out, our chest wall goes back down, that pressure gradient changes back to a low pressure, or negative pressure I should say, and we have our diaphragm that comes back up. So there's really no huge easy process that expels that CO2 back out. So that's why you always have to think. The inhalation process is very easy, very simple. We really don't think about that. But the exhalation process takes more effort. So let's just jump into some terminology. And like I said, we're going to look at tidal volume and rate specifically, and kind of everything that goes into the aspects of those theories. All right, tidal volume, a little history on tidal volume. If you look back 15, 20 years ago, we dealt with tidal volume completely different than we do now. Tidal volume was used in a completely different way, and what they attempted to do is they attempted to inflate the alveoli, inflate the chest cavity as much as possible. So when we think about tidal volume now, and we compare it to earlier, they used to use 10 to 15 mils per kilo for their tidal volume based on ideal body weight. So they were given tidal volumes greater than 1,000 mils for one breath. And if you think about our physiology, our normal physiology, we don't breathe like that. And if you think about medicine and how it's evolved and your current and new standards, everything we're doing now is based on good normal physiology. We're not going in excess in really anything we do. We've learned that too much fluid causes issues. Too much of everything causes issues. So we're trying to bring things back to a norm. And tidal volume is no different. If you think about how we breathe, a normal person, whether you're a 20-year-old big, strong football player or a small female, we probably breathe between 400 and 700 mils per breath. And that's it. So there's really no reason to add a tidal volume that's any greater than that in normal physiology. Now, I'll lay out a few different things as far as why we may increase our tidal volume. There's a few different strategies in other videos, but for normal tidal volume, for normal patients placed on the ventilator, we want to make sure that we have a tidal volume that's physiologic. And there's a lot of reasons why. We don't want to cause excessive pressures, PIPs. We don't want to have excessive plateau pressures. We're going to dive into that. So we want a tidal volume that's based on lung protective strategy. There's a company or a group of researchers out there called the ARDSNet group. And the ARDSNet group is a group of doctors and researchers that have come together, and their whole sole purpose is to do research and trials, publish papers that show that lower tidal volumes prove better outcomes. So that alone reduces morbidity and mortality. They've published multiple papers on this. You can go to their website. If you go to our website, FlightBridgeED.com, in the blog, there's links to the ARDSNet group, or you can just put in ARDSNet group and come up, and you can read the different papers that they've published on low tidal volumes and higher rates. So nowadays, what we want to do is we want to have a tidal volume that is 4 to 8 mils per kilo, and that's a pretty big range. Most protocols out there now start at 6 to 8 mils per kilo. And I always teach to start at 6. 6 is that middle number. There's no reason to ever go above 6 in most patients. And like I said, there's a few outliers out there we'll discuss later. But 6 mils per kilo gives you a very good physiologic tidal volume. And we want to base this on ideal body weight. So a physiologic tidal volume, let's say for an 80 kilogram ideal body weight patient, is 80 times 6 is going to be 480 mils. And if you think about that, for a 5'10" male, 480 to 500 mils is a very good physiologic tidal volume. If you think back to how you tested, whether you're a nurse or you're an EMT or a paramedic, we were taught, specifically paramedics and EMTs, that you give a breath between 500 and 800 mils per breath. And that's how you were taught to use a BVM. You regurgitated that constantly. Well, that's all we're doing. We're giving a tidal volume that's very physiologic. You're not going to cause excessive pressures. You're not going to cause barotraumas. You're not going to cause high plateau pressures. So very, very important. Tidal volume is always represented in mils. So again, 400 mils, we're not using cc's to represent tidal volume. It always should be sufficient to overcome dead space and supply alveoli with a proper oxygenation, or I should say the proper amount of gas to provide good gas exchange. Well, what does that mean? We have actual dead space. We have anatomical dead space, and we have dead space in our equipment, whether it's our ET tube or our vent circuit. And we lose quite a bit of dead space based on each breath that we deliver. It's important to understand minute ventilation, and we're going to look at minute ventilation here in a second. But minute ventilation is tidal volume multiplied by rate. That is an overall minute ventilation that we need to try to achieve every minute. We also have to understand that minute ventilation doesn't equal alveolar minute ventilation. And those are two completely different concepts. The amount of volume that we deliver each minute is completely different to the amount of volume that reaches our alveoli for gas exchange. So we have to understand that. So we have to have a sufficient amount of volume to overcome the dead space that we lose every breath to have optimal gas exchange. And what I mean by gas exchange, remember, gas exchange is the offloading of CO2, so our plasma and our hemoglobin can pick up that oxygen, and the offloading of CO2, the opposite direction, to go out and be expelled out, to be metabolized using the carbonic acid buffering system and our respiratory buffering system. So we have to have good gas exchange based on having the dead space in mind. Well, what is dead space as far as how much volume do we lose? In a normal adult, let's say an 80 kilogram male, you can calculate this in two separate ways. Number one, for an adult patient, you can simply use 150 mils per breath. that's the amount of volume you're losing per breath that doesn't reach the alveoli for gas exchange. So if we were going to give a male that's 80 kilograms, 500 tidal volume, they're actually only getting approximately 350 of that to their alveolar level. So that's significant when you look at that and calculate that over 1 minute. For a pediatric patient or a patient that may be small, you use a different calculation, and it's 1 mil for every pound of body weight, not in kilograms, but body weight. So 1 mil for every pound of ideal body weight. So you utilize that, and that's why 150 mils for an adult is very useful, just to quickly calculate that. But in a pediatric population, neonates, peds, kids, small female adults, small people, it's better to use that 1 mil per pound of ideal body weight. Now let's move on. Obviously, we need to identify somebody's ideal body weight. Their ideal body weight is utilized based on a calculation, and all we're doing is we're calculating somebody's weight based on their height. If you look at a male that's 5'10", if he weighed 400 pounds, his lung volume, his lung size, his capacity is no different than a 5'10" male that weighs 200 pounds. So we can't utilize their actual current weight to calculate tidal volume, or you're going to get excessively high tidal volumes. So that's where you have to look at their height and what their weight should be. Just because they're overweight doesn't mean that you can put double the volume in their chest and their lungs. That's absolutely false. So we have to calculate ideal body weight. We're going to learn to calculate that later on when we start using calculations. But just keep that in mind, that you always look at somebody's height and you calculate it in that way. When we look at respiratory rate is the second ingredient to your minute ventilation. Well, this is something that we have to understand. Respiratory rate and another concept called frequency. On your ventilator, you have a set respiratory rate, and that's going to be set based on the approach of treatment. Well, what does that mean, approach of treatment? We utilize our respiratory rate, we utilize our tidal volume based on the physiology of our patient. We can understand everything regarding ventilator management. We can understand all aspects of ventilator management, but if we don't know how to apply these concepts to our patients and utilize it in a way that's going to optimize their physiology, then we're going to be lost. So there's a very, very good way to look at your different patients, and we're going to learn that in later videos. But we want to look at respiratory rate based on the approach of treatment. And the two approaches of treatment to just kind of weigh in your mind are an obstructive approach. And that obstructive approach is based on either COPD or asthma. Those are the only two patients that fall into that category. The other approach is the injury approach. Every other patient that we take care of would fall into the injury approach if they did not have asthma or COPD. So that makes it very easy to look at your patient and say, all right, this is an obstructive patient. I'm going to go this approach. I'm going to do a rate based on that approach. Or this is an injury approach, and I'm going to do this approach. And all we're doing is we're looking at respiratory rate based on that approach, and we're gauging that respiratory rate based on that. So for an obstructive patient, an example, you're going to go with a lower respiratory rate. If you think about your overall respiratory cycle, right, your respiratory cycle is based on your inspiratory phase and your expiratory phase. If you lower your respiratory rate down, you're adding to your expiratory phase. If a COPD patient is breathing very tachypnic, they have a prolonged, increased, constant inspiratory phase. They don't ever allow themselves to exhale fully. So it would make sense in those patients to drop that rate down into the 10-12 range. In contrast, if you have an injury approach patient, which is everybody else, the whole point of the injury approach is to protect those lungs from further harm. And so to do that, the protection is the actual tidal volume, to make sure that tidal volume is lower than normal. We don't want to overinflate. Well, we have to think about overall minute ventilation. And if we have a lower tidal volume, that means we have to have a higher rate. So for an injury approach patient, you want your rates higher, 16 to 18 per minute. And that's all we're doing. Very simple, two different approaches. And again, we're going to go through the injury approach extensively, the obstructive approach extensively in later videos. But I just want you to understand that the respiratory rate is based on that approach. We also have to understand that respiratory rate is based on CO2 regulation. That your respiratory rate, your tidal volume, your overall minute ventilation is equal to ventilation. And ventilation is aspects of CO2 or PaCO2 regulation. And this has a direct correlation effect of our pH. So we have to understand that your overall minute ventilation is a product of respiratory rate, as a product of overall tidal volume, and that we have to have an adequate minute ventilation to provide good gas exchange because of that dead space that we just discussed, to have good CO2 regulation. So what are the commonly encountered complications that occur with an increased respiratory rate? Well, we know that in a ventilator patient, based on the mode of ventilation, that if you have a rate that's too high, we're going to blow off too much CO2. If we blow off too much CO2, we're going to have issues based on if this is an obstructive lung patient. We're going to decrease that exhalation time, so that's going to cause a significant problem with air trapping and potential auto PEEP. If we raise our rate too high, we can start having problems with our pH. There's a direct correlation with your PaCO2 and your pH, like I said, and they counterbalance each other. For every change of 10 centimeters of water for every change of 10 millimeters of mercury of your CO2, you have a change in pH by 0.08 in the opposite direction. So an example, if you had a pH of 7.0 and your PaCO2 went up by 10 millimeters of mercury from 40 to 50, you're going to have a drop in pH by 0.08. So your pH was 7.0, your CO2 was 40, your CO2 went up 10 points to 50, your pH now dropped from 7.0 to 6.92. So very important to understand PaCO2 equals pH. Respiratory rate is a big thing regarding ventilation. It's going to affect that. So we have to be cognizant of that. The other aspect is frequency. And I said there's a difference between respiratory rate and frequency. Frequency is the actual amount of overall breaths taken, including ventilator triggered breaths and breaths that the patient is actually receiving based on what you put in the ventilator. So if you put 18 breaths in the ventilator as the controlled set rate, but the patient's sedation is not adequate, or they're in assist control and the ventilator is triggering based on the poor sedation, or even the aircraft or ambulance vibration, if you look on the ventilator, you'll see a frequency, and that is reflective of total breaths given based on all aspects. And then lastly, what patients would benefit from a lower rate? Well, we just said those obstructive lung patients that optimize the exhalation time. So these are very important aspects of overall minute ventilation and overall understanding of how all this plays into the obstructive approach, the injury approach, good physiologic tidal volumes, not causing harm to our patients, and this is a great foundation to move on to the next video. I hope you enjoyed this video. If you have any questions or comments, please don't hesitate to email me. I want your comments. That's how we all learn. Good dialogue, collaboration is essential. Please subscribe, put your comments in, click like, and I will see you on the next video. Thank you.